Um, Welcome everybody to episode 4 of our Power Hour series. Really grateful for Hannah to be doing this session for us. Um, uh, we have had 3 previous episodes with good engagement, and so hopefully this episode is of use to you as well. We're going to be talking about professionalism and ethics, and just talk to some scenarios and talk to some principles. But I'll let Hannah introduce herself a little bit more, and then she can kick off with the session. Hannah, over to you.
Thanks, Isaac. So my name's Hannah. I'm near peer fellow at Bath. So I'm a newly qualified GP who trained in both Bath and Swindon patches, and I'm working in Wiltshire at the moment. And we've got some time today to talk through quite the broad topic of professionalism and ethics, and navigating some of those grey areas that we might come across in GP training. And just to kind of reassure everybody that there's not really a black and white straightforward answer with any of these things when it comes to some of the things that we might be talking about today. Often there's kind of conflicting advice, or there's a few things that you might want to be thinking about, and so most of these kind of scenarios that we might talk through are kind of based upon kind of reasoning, reflection, acting with kind of honesty and integrity, rather than it just being one right answer. So what we're going to do is just go through a bit of the principles of kind of what professionalism means, and explore some of the GMC expectations that are set out for us for professional behaviour as doctors, and then maybe practice reasoning through some of those grey area scenarios with some cases that may or may not come up in your GP training over time, or as and when you qualify as a GP. Through there. So to start with, what is professionalism? So the GMC will nicely define that for us as professionalism is a commitment to values, behaviours and relationships that underpin public trust in doctors. And there's some core principles that they refer to. And those are integrity and honesty, respect and compassion for the patients, colleagues, their families, competence and accountability, teamwork and boundaries, and reflection and self-awareness. So thinking about the kind of the GMC's domains of good medical practice and how that sits within our requirements of professional behaviour. So that's split quite nicely into kind of similar categories. So knowledge, skills development, patients, partnership, communication, colleagues, culture and safety, and trust and professionalism. So thinking about what those things really mean. So knowledge, skills and development means that as doctors, as GPs, we must have necessary medical knowledge and skills for your role, and you need to keep those up to date. So kind of core things to be thinking about as a GP trainee is maintaining your clinical competence. So, your things that are required of you, your BLS, your safeguarding qualifications, etc. But also just being aware of what your level of competence is. So knowing your limits, seeking help when needed. Engaging in teaching and training, both going to teaching but also providing teaching as well as an important part of our training. Engaging in CPD, so that means continuing professional development. It's a term that you'll probably hear banded around a little. And that basically just means keeping on top of new things coming out, whether that be through your GP training mornings, or that's going to courses, or evening sessions, etc., and then reflecting on those and what you've learned from them. And then also part of that knowledge, skills and development category would also be keeping kind of accurate and up-to-date records. And that partly comes into practice with our training portfolio that we hold as GP trainees. So the second domain, patients, partnership and communication. So that focuses on our working in partnership with patients, how we listen to them, respect them, and try to communicate clearly with them. But that also covers our communication skills with relatives and colleagues, and focuses on things like shared decision making, so coming to a decision with patients based on their preconceived ideas, their wishes, what their family what they may have told their family they may want, or what their family are aware of their previous wishes, and just involving patients in those decisions. It also touches on a bit of being honest and empathetic when we're communicating with patients, especially if we are communicating bad news or sensitive information, but also respecting confidentiality and any cultural differences between ourselves, patients, and their families. And the next category, kind of colleagues, culture, and safety.
Just
So
very, just
that's
very quickly on that previous thing, Hannah. Sorry to interrupt, but I
yeah,
think
it's fine.
I think that area, especially for us as IMGs, in terms of communicating with patients and informed decision making and explanations of the disease progression and things like that. That is one area that I personally found a bit challenging when I came into the NHS. So I think we just want to just mention that very quickly. Yeah.
Yeah, I think it's something even in in the UK, people that have been training in the UK for a long period of time, this kind of shared decision making has had lots more focus in recent years, I would say,
Mm.
and it is something that is much more at the forefront at the moment in terms of how the expectation is of us to kind of behave or develop relationships with patients and their families. And there's lots of research going on around that area too. But so I would say don't feel alone. That feels a bit more of an alien concept, because there are lots of people
Yeah.
in who have been working in the UK for a long time who also do find that will find that difficult too. There are things that you do find difficult. It's about kind of sharing those with your colleagues and your supervisors, and kind of developing those skills over time. So we were just going on to colleagues, culture, and safety. Am I right?
Yeah.
Yeah. So that's about kind of contributing to kind of safe and fair working environments, trying to act if you see any risks for colleagues, patients, or any poor practice. So this kind of category talks about kind of respecting your colleagues, working within a team, making sure we speak up about any patient safety concerns that we have, and try to kind of support the team to be a kind of positive, inclusive culture and place to work in. So things like contributing to handovers, making sure that kind of all colleagues' perspectives are taken into account, things like that. And then domain 4, so trust and professionalism. So this is about kind of upholding public trust. So the expectation is that we are honest, we're responsible, we act with kind of integrity, both inside work, but also outside work. So kind of maintaining professional boundaries, but also, this slightly touches on that kind of outside of work. Again, having that professional accountability to behave appropriately, because we've need to be seen to be doing that in both our professional lives, but also in our personal lives, and partly, I guess, I'm thinking a little bit about kind of social media and things like that, and we might touch a bit about that later as well. And then, so thinking a little bit about kind of medical ethics as well as another kind of framework to use when we're thinking some of these complex scenarios. So the 4 pillars of medical ethics include autonomy, so that means respecting the patient's rights and informed choice. So I've just tried a few examples here of something that might come up in practice. But for example, a patient declining statins is an example, a medication. And if we can document and have made an informed decisions with even more information to be able to make that choice, so they decide not to go ahead with that treatment or that medication, we do need to respect their autonomy. Beneficence, that's acting for the good of the patient. So We're always trying to have kind of at the forefront of our mind what patients' best are. An idea would be kind of encouraging to screening lots of people the forefront of that basically means harms. So trying to conscious of avoiding any additional harm to the patient. Things like doing antibiotics for viral illness to prevent harm or increase antibiotic resistance. And that probably comes up quite a lot in general practice, people thinking because they're often you need antibiotics, and sometimes you know sort of hesitation around the lines that might be a virus and actually give antibiotic about, or you might have resistance to these in the future. So, that that we might come across, and less complicated one than some of the things that we speak about later. And then
Just very quickly, Hannah, 1 second. So sorry. Your voice is breaking a little bit, but it might be just on my end. Uh, um, so I'll just maybe if the other people on the call can hear, if they can just give a quick thumbs up. Do you want to just say that again? What, just about justice?
Category about justice is provide kind of fairness and equity in the care and the resources that we provide. So kind treat everyone fairly and equally that we do see. Is that any better?
It's still bad on my end. I'm not sure if Marcelina can just uh, put a comment in the chat. Were you able to hear that, Marcelina? Sorry about that. Okay, no worries. I think yeah, it's still interrupted. Yeah. So I think it's probably on your end, Hannah. Sorry about that. Um, did you want to just use a different Wi-Fi if that's possible, or?
I'll try. Bear with me.
Oh yeah, that sounds a bit better.
Can you hear me? Is that any better?
Yeah, that's much better. That's much better.
Okay, fab.
Sorry
Sorry about
about
that. No. Can you see the slides?
Absolutely.
Okay, fab. Fine. So I guess the thing to think about, which I was alluding to at the beginning, is that often, ethical challenges that we come across in general practice have competing principles. So we might think that some of these professional kind of expectations of behaviour that the GMC outline are important when we're thinking about how to tackle them, but also as are some of these pillars of medical ethics, and they don't always align. But what we're aiming for is kind of a reasoned decision that we can justify, that is balanced and takes into account all of these factors, rather than, like I was saying, an absolute yes or no or black and white answer. So some of the things that I think can be challenging. And I think Isaac alluded to this a little bit earlier, was that kind of cultural expectation of autonomy and shared decision making might be something that's less familiar to yourselves, and like I was saying, it will be less familiar to other people that you come across that you're working with as well. And it's something that I feel like a lot of people are working on at the moment. So again, it's something, if you're not sure about, to ask for support with. Other things, kind of professional boundaries or hierarchical differences between places where you may have worked or different places you may have worked before, and then if you're new to kind of NHS role and how that works, and how to kind of raise concerns and whistleblowing if there have been processes that you're kind of aware of in a previous role, or if it didn't exist in a previous role and now there is kind of a process to doing that. And again, I would just encourage you that if you're not sure, but something has made you feel uncomfortable, or you don't quite understand how that decision was made, anything like that, share that uncertainty. So with your supervisor or with a colleague that you feel would be supportive, who might be able to help you navigate how that decision has been come to, or where to escalate concerns to. So I was going to go through a few cases just because I think it makes it kind of a bit more relevant in terms of what we might come across in GP. So if we just kind of go through those now, and interject as you want to if there's anything that you think of. Case one, so you're running 45 minutes late in a GP clinic. The next patient is a 32-year-old woman who is distressed and tearful after having had a miscarriage a couple of weeks ago, and she insists that she just needs to talk to you for a minute. Meanwhile, the waiting room is full, and there is a patient with chest pain. That you're aware of, you need to see quickly. And to complicate matters, the receptionist messages you to say that someone has already complained about the wait. So what kind of things might come up in terms of thinking about this? So I guess thinking about some of these principles, so beneficence, so patient's best interests. So whose best interests do we need to value first in this scenario? Is it the obviously very upset patient who has gone through traumatic miscarriage? Is it the patient with chest pain? Is it the patient that's complaining? And justice, so trying to treat everyone fairly in this scenario. Who deserves our time first right now? And I think if you asked lots of different GPs, 100 different GPs, you'll get 100 different answers in this scenario. So it's about kind of exploring those thoughts and coming to a reasoned decision. So another thing I guess to think about is how do we show compassion to all of these patients whilst maintaining fairness?
I had a very similar, sorry to interrupt. I had a
No, go.
very similar scenario of a patient who was in the waiting room, and but a patient who had come after them was much more critically unwell, and it was quite clear that we were prioritizing that patient. We called that patient in, were trying to sort them out, and then the patient who had come in first, obviously, tried to kick off, and then it can get quite challenging to patients because they don't have obviously the full information about the rest of the people in the waiting room. And so we often tell them when they are coming into our department, into our waiting rooms, that you might have an appointment slot, but we would sometimes be prioritizing people who've arrived after you because of uh, the the criticality of their illness. And so we actually put out signs in our department about this as well, just to kind of let people know that there might be somebody who's coming in after you who might be getting seen to first. And so
Yeah, is that urgent care, Isaac, you're talking about?
yes, yeah.
Yeah. I guess I wonder in that scenario whether is there more of an expectation to wait rather than like having an assigned slot compared to being in a GP practice, or?
So we do have both actually. We have people who can
Okay.
walk in, and then we have appointment slots as well. So
Okay.
sometimes people who are given an appointment slot don't get seen at that time, and they get seen probably 45 minutes later, or an hour later sometimes as well. But we try and
Mm,
make
mm.
sure that everyone understands that we are not ignoring them.
Yes. Yeah. Yeah. I guess there's I don't know, certainly in my practice we don't have anything like signs or anything up like that in the waiting room. Um, I think probably as a duty GP, there'd be, there's definitely a role for that. And I think often actually that does get explained to patients who are coming in on those like on the day appointments, emergency
Absolutely.
contacts, that there is one or two duty doctors working this afternoon. And if someone came in more unwell, you may need to wait to be seen. It's not kind of a set appointment time. So I think sometimes that I suppose that's kind of drawing on that honesty. So being honest
Mm,
with patients. Um, you obviously have to be careful to respect the confidentiality of the other patients, don't you?
absolutely.
So, we can't be telling Joe Blogs in the waiting room that, Mrs. X is got chest
Yeah,
pain or something.
yeah,
But I think we are able to say, like you say, that we're dealing with someone who is more unwell, or there may be someone more unwell, and that's why there is a wait today, or in general, it may not be a specific time that you are seen because of um, how unwell other people are at the time. So I think that kind of is a bit of a balance, isn't it, between trying to offer compassion to the people that are waiting, trying to behave fairly for all the patients that are there, but also making sure that we recognise that clinical need, and prioritising someone who is the most unwell, but communicating that delay to the other patients with kind of some transparency, as much as we can, and apologising to them for that, for that delay, offering reassurance that they will be seen. So I think it kind of draws on lots of different domains of the kind of GMC practice.
mm,
So providing safe care. So the safe care here is probably managing the person with chest pain immediately, but treating patients politely, managing expectations honestly, communicating with those other patients as to why there may be a wait, apologising for that, and then being open with trying to be open and honest as much as we can with the patients as to why things are going as they are. Um, Fine. And then I guess partly also just drawing on that fact of kind of remembering to that this is to recognize your level of competence here. So to be not overextending yourself. So if you need help in this situation, then it's okay to ask colleagues for help, assistance in managing that. And that might not necessarily always be help from another doctor, for example. It might be that you need to see the patient with chest pain straight away, but you need reception to help you kind of explain to the other patients that are waiting, and managing them. So drawing on your colleagues in that kind of situation as well. So the second case, I think I put in just because I think it can be a bit tricky, and it probably GP is one of the only places where it might come up, unless you've got like a sexual health job or something like that. So this is kind of a contraception conversation with someone who's under 16. So a 15-year-old girl requests contraception, and tells you she's sexually active with her 20-year-old boyfriend. She begs you not to tell her parents, who are very strict. She appears mature, she understands the risks, but she also mentions that her boyfriend sometimes gets angry and pressures her to have sex without condoms. Um, hmm? So I think a few things to think about first of all, and then there's some specific frameworks to go through in terms of managing these sorts of scenarios, so under 16s, but also kind of contraception in under 16s as well. So thinking about autonomy here, so she's able to communicate. You believe that she kind of understands the risk. She's clearly communicating with you. Confidentiality, she's asking you not to tell her parents. So there's quite a lot to consider around that. How do we assess? We need to think about assessing her capacity. So whether she has capacity to make this decision, does she truly understand the risks, and how do we assess and document that? So and then thinking kind of more broadly, you know, in this situation or in other situations, when does confidentiality give way? So in this situation, I suppose, if we hadn't have said about the relationship with her boyfriend and her feeling pressure, then we may have been maybe more likely to think about maintaining that confidentiality potentially. But in this situation, actually, are there some safeguarding concerns here? She's got an older boyfriend, she's feeling pressure to have sex, and whether that's all the time or not, she's disclosed that to you. So in this situation, we can break confidentiality and with her best interests in mind, because it sounds like a potentially unsafe situation that she is in. So thinking about a safeguarding referral for the social worker team to look at this in a bit more detail. I'm going to come on to Gillick and Fraser guidelines in a moment, just because I've got a slide on that. And then other things I thought about this case is kind of, who might you speak to for support in this situation? How might you document what she's told you? So I think in these sorts of scenarios where there's concern about her age, safeguarding, but also her capacity, we have to be really clear in documenting, what the patient has said. Assessing her capacity. So does she truly understand, her decision, the risks, the benefits or the risks, and where that may leave her, and is she able to retain that information and communicate that back to you clearly? Would be assessing her capacity in some sense. So trying to document those sorts of things, but also on lots of our GP systems, there will be kind of frameworks about Gillick and Fraser, Gillick competence and Fraser guidelines, which are useful things to pay reference to. So if you use System 1, for example, there's a little tool that you can use to document that you've thought about that in this situation, and it will prompt you of what things to document clearly. So that's something to also think about. And then I guess with the safeguarding concerns, I don't know about you guys, but I absolutely would not have been confident dealing with this situation as a trainee. I absolutely would have been wanting to speak to somebody for support, whether that be my supervisor. Initially, it probably would also be the child safeguarding lead in a practice. So in your practices, there will be an adult and child safeguarding lead. And this is the absolute right sort of scenario to be running past somebody else saying, this didn't feel right to me, and I want some support in how to act on this because I think it needs acting on, and they will be able to guide you in how to do that. So they're a very useful point of contact, and people that when you're in a GP practice placement, it's worth knowing who they are from the very beginning for any safeguarding concerns, so that you can access some support in terms of how to best act on any queries that come up. And then I guess kind of just pulling on the ethical pillars that may be in conflict here. So as we mentioned, we're trying to uphold all of these standards, but they don't always align, and there will be conflicts. So trying to respect her autonomy, which is wanting contraception for her relationship with an older person who may or may not be treating her appropriately, versus not doing harm, and actually she may come to harm in this situation. So it can be a really tricky balance in these scenarios of trying to adhere to all of these kind of pillars of ethics or professionalism, GMC standards. So just a little bit more about kind of Gillick competence, Fraser guidelines. So Gillick competence, so a child under 16 can consent to their own medical treatment if they have sufficient understanding and intelligence to fully understand what's involved. That needs to be documented very, very clearly. So traditionally, we wouldn't necessarily assume that anyone under 16 has competence to make those decisions. Often it's the parent that will be making those decisions on the child's behalf. In this situation, or around contraception, that particularly may not always be possible. But also, there may be other scenarios where a child comes to an appointment, a 15-year-old comes to an appointment, for example, by themselves about something much less concerning, but you want to ascertain whether they really are kind of understanding what's going on. And then Fraser guidelines are particular to contraception. So we can provide contraceptive advice or treatment to a girl under 16 without parental consent if we're happy that they understand the advice. They cannot be persuaded to inform their parents. So it's always very important to try to persuade them or try and ask them if they're able to have that conversation with their parents. Because ideally at this age, sex under the age of 16, we would want the parents to be knowing about it. Technically not legal, especially if the partner is older. So we would always ask them to be to tell their parents, but sometimes there may be situations where they really feel like they can't. And I guess in that situation, part of kind of acting with her best interests is that actually she may continue to engage in sexual activity whether or not we give her contraception. So if we don't, for example, then she may come to harm. She may end up having sexually transmitted infection and unwanted pregnancy, for example. So those would be reasons to kind of put forward to consider providing contraception for her. So the other kind of aspects of it, her health is likely to suffer without advice or treatment, and it is in their best interests to provide the advice or treatment. And so it's a bit of a balancing act in this scenario. I think in terms of the main things to take away from it are kind of exploring the patient's maturity and understanding, being sure that she's not being coerced, so really exploring that relationship with the boyfriend a bit further, making sure that she is, she is truly consenting to sexual activity rather than being pressured, and then seeking safeguarding advice, and telling her that you may need to do that because of that situation. And that can be an uncomfortable conversation in itself, telling people that you need to refer to safeguarding. But often I think if you phrase it in terms of, we need to do this to access some additional support for you, or something that's something that phrases it as a positive benefit to the patient, can sometimes it can land slightly better, rather than them feeling ridiculed, for example, that they've behaved in a certain way or have come to you with a certain problem. And then I think the really key take home from this is documentation. So the main thing would be kind of documenting this really clearly. And I guess the other kind of key thing is actually in this case, we can break confidentiality. So confidentiality is not absolute. So a safeguarding concern can override that if you suspect that the patient will come to harm. So I've got a couple more cases, so we'll see how we're doing for time. We'll just keep going at the moment. But so case 3 is
just very quickly, I don't want to interrupt you. There's just been a little bit of an emergency that's happened over here. Are you happy to
Okay.
continue? I'll join you back as quickly as I can. Yeah?
Yeah, no problem. Yeah.
Okay, I'll join as quickly as I can, all right?
Okay, no worries.
And then
Um,
yeah.
so the third case is an unsafe colleague. So you notice, for example, you notice a senior GP partner smells of alcohol and seems distracted during an afternoon surgery. Later, a patient quietly mentions to you the doctor seemed slurred. in their speech. You're new to the practice, you're on a short-term rotation, and you really don't want to damage any relationships. So I guess, what kind of things might we think about in this scenario? So what are your professional and ethical duties here? So both to your colleague, but to the patients that they may be seeing. Thinking about how the GMC expects us to handle these concerns about colleagues. Is there a risk of harm to the patients? And then what might be the most professional way to raise a concern safely? And again, this is one of those scenarios where the kind of pillars of ethics might conflict here. So beneficent, duty to the patient, for everything to be in their best interest, and justice, acting with justice, so providing kind of loyalty to your colleagues. So I think the things to think about, so the GMC would expect us to act. So there is a duty for us to act when we feel that patient safety is at risk. So it's not something that we can ignore. Their kind of good medical practice guidelines says you must protect patients from risk of harm posed by another colleague's conduct, performance, or health. So I guess in this situation, how might we deal with it? So we need to avoid assumptions here. So, you suspect that your colleague is not behaving correctly, but maybe gathering some facts. So, trying to, if you have a relationship with them, potentially speak to them. And see if we can gather a bit more information about how they're feeling or what might be going on. Often in these situations, there is something else going on. So there might be something else going on in this person's life which has triggered them to behave in this way at the moment. If you have a relationship with this person, it might be about having an open and honest conversation with them about what's going on at the moment. If you don't feel able to do that, then maybe trying to discuss confidentially with your supervisor within the practice, or anyone else in the practice who may be kind of more senior to you, to be able to provide you with some support in this scenario. And getting advice from them about how to deal with what's going on. I think in this situation, if you're new to a practice, or even as a trainee in a practice, it would be extremely difficult to act on that observation. But I suppose the most important thing to consider is the patients, and our duty to kind of act professionally. So even if it makes us feel uncomfortable acting on this situation, probably do need to do something about it. But I would encourage you as trainees, if you ever did come across anything like this, or even not something quite as obvious, maybe you've noticed a colleague speaking to patients in a certain way that feels uncomfortable, or that you don't like, and actually that isn't because the colleague is under the influence of any alcohol, drugs, or anything like that. It's just a reflection of how they're feeling at that moment. But certainly initially having a conversation, if you can, with that person to ascertain what really is going on, or if not, raising that concern to someone else in the practice who might be able to have that conversation for you, is the most important thing. Lovely. So case 4. So this is a bit of a cultural conflict situation. So it's a 70-year-old woman, recently arrived from Ukraine, speaks very little English, and she's found to have metastatic cancer. Her adult children ask you, please don't tell her, it would kill her to know about it. The patient, because of her language difficulty, doesn't speak clearly to yourself, but often relies on her family for communication. So lots of communication has been going through the family at the moment. But during a consultation, she does manage to ask you whether it's serious. So thinking about kind of what challenges this might pose. So it probably intersects a lot of these kind of pillars and guidance that we've spoke about so far. So respecting kind of patients' autonomy. So establishing really, she does want to know whether her relatives feel that she may not not want to. Really at the center of this is the patient beneficence, so acting in her best interest, what is in her best interest, but also showing some cultural sensitivity here, that that there's a bit of a language barrier. It may, her family may well be right that this is something that she may not want to know about, and how do we kind of balance all of those? How do we ensure kind of valid consent? So in this situation, how do we get consent from her to share with her relatives? How do we get consent for her relatives to communicate on her behalf? How do we come to those shared decision-making ideals? How do we make decisions about her care with her and with her family, if that's something that she wants? So, one thing would be obviously using interpreters. And we can do that relatively easily in primary care, through the what's it called? I've forgotten the name of the interpretation service, but there's a telephone service where you can have a interpreter live on your consultation there and then, and it's really easy to access. And sometimes that is what's needed in these situations. So we do need to ask her whether, some questions herself, really, don't we? We need to ask her, one, whether she wants all of her family to know what's going on, one, how much she wants to know about what's going on. Do we have consent from her to share between family members as well, about what's going on with her care. And then thinking about kind of GMC guidance on honesty and openness. So good medical practice would ask us to be open and honest about a diagnosis, prognosis, and treatment, and that it would model the use of interpreters to ensure that we've got informed consent, to involve kind of family or communicate with other people about her care. So I guess in this situation, might we explore the family's beliefs respectfully? So it's important to listen to them, and prioritize that communication with them. So maybe establish why they feel that the patient would or wouldn't want to know about the diagnosis or the prognosis. Maybe she does have some pre-existing wishes or beliefs that they're aware of that we may not be aware of. So really important to validate and listen to their concerns, but also make them aware that we do need to prioritize patient autonomy in this situation. So we do need to establish what she wants to know and what she understands. And then maybe, assessing that understanding directly. So that's where our interpreters would come in this situation. So, explaining to her and the family that, we will need to speak to her openly, and then sharing that information sensitively, through interpreters, if that is information that she does want to receive and wants to know about. And it sounds like from the question that we posed in that scenario of her asking whether it's serious, she probably does want to know a bit more about what's going on. And it's about kind of balancing that family's wish to protect her, or maybe they are considering things that she's expressed in the past, but also things can change in the moment, and actually at the moment, does she want to know a bit more, and if so, then we are obliged to communicate that very honestly and openly with her about what's involved in the diagnosis and the prognosis of her condition. And I guess in this situation, we'd obviously be trying to involve other teams. Palliative care teams are really good at having conversations around those factors that we might not have time to always discuss in general practice, but kind of previous religious, cultural, previous and current religious and cultural importance, and how to navigate those. So they're conversations that they will have a lot with people at the end of their lives, and they're sometimes very useful people to kind of have involved in these situations, because they're very used to communicating with the patient and the family as well. So they'll be a very useful resource in this scenario. Fine. And then the last one, which we'll just quickly do, if that's okay, is a kind of a social media slip up. So a GP registrar posts a status about an interaction with a difficult patient that day. And you notice the post, and you think, oh, maybe it includes actually some potentially identifiable information. So it does, may not contain the patient's name and date of birth, but actually, could other people identify this patient from the context that has been put online? And if so, what are we meant to do about it? So thinking about kind of GMC guidance on confidentiality in social media. So obviously we're bound to provide confidentiality for our patients. Whether this broaches it or not very much depends on the context of what's in this post. But if you feel that you've got any concerns that it might do in terms of someone will be able to work out what this is about, then it potentially is broaching that confidentiality. And in terms of kind of social media, there's been there has been specific guidance about this. So doctors' use of social media guidance in 2013, and I think it's probably been updated in recent years as well, actually, because it's becoming obviously more and more prominent. But the guidance is that we maintain same standards online as we would do offline. So we need to respect patients' confidentiality, respect respect honesty, but also behave with courtesy. And so, in this situation, even if the name of the patient is not in the post, is it appropriate to be writing a long, lengthy post moaning about a patient interaction that other people may see and pick up on? Probably not. So certainly we know that we can't be posting identifiable patient information, but we also need to be careful with the other things that are being posted. So avoiding any kind of derogatory, unprofessional comments about patients or colleagues on social media. It's that sort of thing that the GMC kind of takes very seriously, and once it's there, sometimes can be very difficult to get rid of or delete. Often these things have some permanency to them. Once they're posted online, someone screenshotted it, and it might come up later to bite you.
The way I think of this is, it's such a simple mistake not to make. And yeah, I appreciate some. Yeah, that's my one line comment on that.
So yeah, what I would say is if you use social media a lot, that's absolutely fine to do, but just think before you post anything if it's related to work, because you don't know where that information is going to go, but also just need to make sure that everything is like what we've spoken about already. We have a responsibility to act with all of these requirements within work, but also outside of work, and our social media presence is very much involved in that as well. So yeah. So kind of just take home messages that I've said quite a few times. Ethical dilemmas rarely have one right answer. There is often conflict between the pillars and GMC guidance that we've spoken about, and it's just important to be aware of them, use them as a bit of a compass to navigate any kind of situations that come up that prove ethically challenging. And if you're not sure, ask, because probably lots of people wouldn't be sure in that scenario, and there's absolutely no shame in asking for help or extra thoughts, assistance. There will be more senior people in your practice who've come across something similar before. There will be the safeguarding leads who know a little bit more about what to do in certain situations. So certainly definitely ask for support. That's all from me, I think.
Thank you so much, Hannah. Thank you for putting up with all the issues we've had with IT,
That's okay.
and then my emergency over here, and then um, really good session, really good cases that you've picked up. I think this is something that, even though I've heard this talk on various forms and many different forums, it's so important to kind of keep refreshing, even as seasoned doctors, to remind ourselves of those basic tenets of professionalism. So yeah, thank you so much, Hannah, and thank you for people who joined. Again, hopefully it was useful to you. This recording will be uploaded to YouTube, and you can access this later. I'll stop the recording now, and then people can ask questions if they need to.